Hello, I'm Lauren McCafferty, and I'm an ultrasound fellow at University Hospital's Cleveland Medical Center. As part of my series on how to use point of care ultrasound to augment traditionally landmark based procedures, next I'll be talking about the use of ultrasound for shoulder dislocation and reduction. Why use ultrasound? It's a quick and accurate diagnostic tool. You can perform ultrasound at the bedside and know within seconds whether or not a patient's shoulder is dislocated. It's a much more efficient time to diagnosis compared to x-rays or other imaging, which usually take a lot more time. Ultrasound can accurately confirm reduction immediately. While there's benefit in any case, it's especially useful when you aren't exactly sure whether or not the reduction was successful. You can know right away whether you can proceed with standard post-reduction care or if you need to continue trying to reduce the shoulder. This could potentially avoid sending a patient off to radiology only to find out that the reduction wasn't successful. And in that case, there's a good chance the patient will need to be resedated, will have to receive additional x-rays, will require further monitoring, and their overall ED stay will likely be longer and more costly. This was a systematic review and meta-analysis from 2019 looking at the diagnostic accuracy of point-of-care ultrasound for shoulder dislocation. In the final analysis, a total of 7 prospective observational studies consisting of 739 patient assessments were included. Ultrasound was compared to confirmatory X-ray or CT, and the majority of these studies were performed by emergency physicians. The overall sensitivity and specificity for diagnosing shoulder dislocation were 99.1% and 99.9% respectively. This is really good, especially considering the benefits that I previously mentioned with little to no risk to the patient. They also found that rates of confirming successful reduction were nearly perfect. Surprisingly, they also found that ultrasound was highly sensitive and specific for diagnosing associated fractures. However, the confidence intervals were fairly wide, so further study is needed to better determine the diagnostic accuracy of this. And finally, while this wasn't one of the main variables studied, they found significantly expedited time to diagnosis with ultrasound. So overall, ultrasound has great utility for shoulder dislocation and reduction in the emergency department. For probe choice, you can use either a curvilinear or a linear probe, depending on personal preference, as well as the patient's body habitus. If at all possible, it's best to have the patient sit completely upright with their arm held adducted and flexed at the elbow. It helps if you stand behind the patient and have the ultrasound machine in front of both of you. You'll place the probe in a transverse orientation relative to their body, along the posterior aspect of the shoulder, parallel and just inferior to the scapular spine. Just like this. You might need to move the probe slightly laterally to bring the glenohumeral joint into view. So this image here on the right is a patient's left shoulder. So the scapula is more medial, and you'll see that on the right side of the screen. Then the glenoid kind of extends off of that. And then the humeral head comes in and sits right next to the glenoid. The infraspinatus muscle and tendon come in and attach on the humeral head. So it's important to remember that the probe is on the patient's back. So structures at the top of the screen or closer to the probe are going to be more posterior, and structures near the bottom of the screen are more anterior, since you're moving away from the probe. So once you get a view that looks like this, you're going to have the patient rotate internally and externally at their shoulder. If they're having a lot of pain, you may need to help them do this. You're hoping to find this. Here we see smooth movement of the humeral head in the joint space. This indicates that the humeral head is in place. If the humeral head were dislocated, either posteriorly or anteriorly, you shouldn't see this nice smooth movement. So if normal is on the right, compared to the image on the left, you'll notice that something doesn't look quite right. Here you can see that you've lost the nicely aligned scapula, glenoid, and humeral head and instead there's a big step off from the glenoid and humeral head. You can actually see an anechoic effusion developing in the empty space between the two. So since the humeral head is now farther away from the probe, this indicates an anterior dislocation. This is by far the most common type of shoulder dislocation. Conversely, here the humeral head is closer to the probe than the scapula and the glenoid, so this is a posterior dislocation. Proceed with a reduction as you normally would. Have the ultrasound ready to go at the bedside, so as soon as you think you might have succeeded, repeat your ultrasound. Again, you're looking at the position of the humeral head relative to the glenoid and visualizing the humeral head moving smoothly within the glenoid with internal and external rotation of the arm. This is demonstrated here. If you see this, you know that your reduction was successful and you can proceed with post-reduction management. If, however, you continue to see a step off or the movement isn't nearly as smooth as this, then there's a good chance that you didn't successfully reduce and you should keep trying. The nice thing about ultrasound is that you can continue to repeat this as much as you want with each attempt. A few quick pros and pitfalls. Pain may limit your exam, preventing you from optimally positioning the patient or performing the dynamic component. However, just do your best and get as good of an exam as possible. Use the opposite shoulder for comparison. Sometimes a patient's anatomy may look a little off. It helps to look at their presumably unaffected shoulder, as their anatomy may just be slightly different, and this is actually normal for them. If you plan to use ultrasound to confirm reduction, it helps to look at their shoulder before you reduce it, even if you've already confirmed a dislocation with x-rays. That way, after you've reduced it, you have something to compare it to. Keep the ultrasound at the bedside so you can immediately scan the shoulder after you reduce it. That way you don't have to wait and have to send someone to get the machine and risk the patient re-dislocating it. And finally, blocks can often help. I'm going to briefly touch on that here. When you're performing an ultrasound-guided intraarticular injection, you'll hold the probe in the same position as previously described along the patient's posterior shoulder. You'll take an 18 or 20 gauge needle and enter the skin about 1 centimeter inferior to the acromion process. You'll be coming in an in-plane approach, and you'll direct the needle in a medial and inferior direction. You'll direct it toward the joint space, maintain negative pressure, and once you aspirate blood, you know you're in the joint space. Then you'll inject 10 to 20 cc's of 1% lidocaine, which you should be able to visualize as it fills the space. A few take-home points. Remember your anatomy. Know that the humeral head, glenoid, and scapula should line up in a normal shoulder. If you see a step off or disruption of this alignment, there's a good chance that there is a dislocation. Use the dynamic exam to your advantage. This will not only help confirm reduction, but also aid in diagnosis as well. Consider an ultrasound-guided intraarticular block. These are well tolerated by patients and can potentially reduce the need for narcotics and sedation. Realize that ultrasound doesn't necessarily replace x-rays, but it's a good adjunct. It can give you a diagnosis within seconds, and while the patient is waiting for their x-rays, you can perform a block and prepare for the sedation and reduction. The bottom line is that ultrasound has multiple uses for shoulder dislocations and reductions, and it's highly accurate. Consider this the next time you have a patient that presents with a dislocation. That's all for now. If you have any questions, feel free to contact me. Thank you.